who's joining us tonight for this webinar on matters COVID. As you come in, I am going to just ask you to mute yourselves, stay muted. You can keep on your videos if you want to, but we ask you to stay muted so that the experience can be very good for everyone and they can get to listen to the speakers without much interruption. If you have any questions that you want to share with this session that you'd like to ask, I ask you to put it on the chat group for now, and we will either read it out during the question and answer session, or if there is time, I will ask you to ask the question yourself. But for now, please join us, stay muted, and thank you very much for joining us this evening. We are very, very pleased to host two renowned professionals in the area of medicine who have accepted generously to be with us tonight as we speak about all matters COVID. And I must say I've received so many questions, a record number of questions for this particular webinar. So I'm sure there's a lot of people waiting to hear from Dr. Githinji and Dr. Alouch. So I think we will start. I do believe we do have our guest today. I think I'll start by introducing Dr. Alouch, who I'm sure is well known to the members of the club. And Dr. Alouch has been in medicine for over the last 53 years, and he's been in the respiratory medicine and infectious diseases domain, and also in HIV medicine. He's a consultant pulmonologist at the Nairobi Hospital, and is also the president of the Pan-African Thoracic Society. So thank you very much, Dr. Alouch, for coming here and donating to us your time. We really appreciate, and welcome to this webinar.
Thank you, Vicky, for that kind introduction, and thank you for giving the chance to talk to the members of the club. Okay. If I may share the screen, then I'll be able to start.
Let me also introduce Dr. Githinji, Gitahi, who I'm sure is not a stranger to anyone here. He has been quite vocal and passionate about all matters COVID, from giving advice to sharing what best protocol is. I'm sure we have seen his video trending quite a bit. So thank you very much, Dr. Githinji, for coming here and being with us tonight. For those of you who don't know him, he's a Group Chief Executive Officer of Amref Health Africa. And very, very passionate about ensuring that healthcare is provided to a lot of our communities in Africa. I think it's said that Africa is the largest African-led global organization, so not a small feat. And he's also been the vice president and regional director for Smile Train International, and is a former managing director of the Monitor Publications in Uganda. So thank you again, Dr. Githinji, for being here with us and agreeing to share in your expertise and in your time at the Current Country Club today. Thank you very much and welcome.
Thank you for having me. Thank you.
Okay. So over to you, Dr. Alouch.
Thank you, Vicky. Can you hear and see my slides?
Yes, I can hear and I can see your slides.
Thank you. Thank you for asking me to talk about COVID vaccine, administration and use in the COVID pandemic. This is a time when the COVID pandemic has had a lot of effects on our lives and our livelihoods and our working. In fact, the problem with the COVID pandemic now, we also got a pandemic of experts appearing in social media, networks, television, and shows, and all giving various expert opinion, experts in inverted commas, regarding COVID vaccination. But it's true, we're desperate doing this because we know very little about COVID, so we need a lot of information, but we cannot trust half of it. It's only in God we trust. All others must bring confidence. So why do we need the COVID vaccine? COVID vaccination will help keep you from getting sick from COVID-19, full stop. And that is very important. And that's what everybody wants. They don't want to be sick. All COVID-19 vaccines available have been shown to be fairly effective, over 70%, 80 up to 90%. We know that over the months we've been stressing on wearing a mask and social distancing to help lower the chance of getting the virus or spreading it to others. But these measures have been shown not to be enough. And we know that the more people are vaccinated, the faster we can get back to our normal lives or a new normal. Clearly, we don't have a normal life at the moment. So why do you use vaccines? Basically, vaccines prevent diseases that can be dangerous or even deadly. They work with one's body natural defenses to help develop protection from a disease. A vaccine helps the immune system to produce antibodies, just like you do if you are exposed to the disease. If you are exposed to the virus or a bacteria, the immune system will produce antibodies to fight the virus or the bacteria. Same thing the vaccine do. After getting vaccinated, you have a protection from that disease without having to have the disease. This is what makes a vaccine such powerful medicine. Unlike most medicines which treat or cure diseases, vaccines prevent diseases. So what is COVID vaccine? There are several of them already in the market, some of them in development. At the moment, there are 4 or 5 which are already been released in the market. And they protect people by this vaccine by the body recognizing there are some parts of the virus known as the spike protein. Those are the red knobs you see on the image. And these are the spikes that are used by different vaccines to make the vaccine that we use. A virus can be used to make a vaccine in different ways. Historically, we'll be using the whole virus or making it dead or weakening to make a vaccine. This has been the method over the years. You can also use pieces or proteins or extract from the virus, like we do in tetanus hepatitis, to make a vaccine. But in the COVID vaccine, it's a new ball game. We're not using the virus itself. We're using the so-called messenger RNA virus, which are made. It's like we're having a synthetic infection and a synthetic agent to make a vaccine. Okay. Now, mRNA technology has been around for the last 10 years. It's been used in cancer quite a lot, but it's only recent in the last 1 year that it's been used in vaccine production for COVID. And the mRNA vaccines give instructions for our cells to make a harmless piece that looks like spike protein. The spike protein is what I've shown you, is found on the surface of the COVID-19 virus. Our bodies then will recognize that this protein should not be there. So they build antibodies that will remember how to fight the virus in future should we have a COVID vaccine infection with us. mRNA vaccine cannot give you vaccine infection because it's not a virus, okay? And it cannot change your DNA, as we'll see shortly, as many people have been worried about. The Pfizer and Moderna vaccine use the mRNA system, the protein that gives the body instruction, as I said before, to recognize the COVID virus that causes the disease so that it can kill the virus before it can make you sick. Now, mRNA is not DNA, as some people confuse it, and does not interact or change an individual DNA in any way. Now, this what terminology which is used often is called EUA, which is an emergency use authorization, which is used for most vaccine at the moment, and is based on the need to use a vaccine quickly to save their lives during public health emergency like we have the pandemic now. It's a shorter process, but no steps are skipped in the safety evaluation. And an EUA does not imply that the authorization was done too quickly or that the vaccine may not be safe, okay? So no COVID vaccine is made using a whole or kill weakened virus, as I said before, and it does not contain pieces of virus. And there are only 2 mRNA vaccines that made with no virus. None of these vaccines can give you a person COVID-19 disease, which some people worry, they feel that maybe if they get the vaccine, they may give the disease. No. So the 4 vaccines that have been authorized by the USA are safe and highly effective against serious illness. And they reduce the number of people going to the hospital, and above all, people may die from the disease. The vaccines require at least 2 doses, that is Pfizer, Moderna, at least 3 to 4 weeks apart. It's important that you get both doses so that it becomes effective. It's only Johnson & Johnson that require 1 dose, and people are wondering whether it will be sufficient, but time will tell us. So how did we make the vaccine so fast? I mean, COVID-19 or SARS coronavirus has only been around for 12 months, and within that time, we discovered the disease and we already made a vaccine. This is because we already knew a lot about information about our coronavirus from the other SARS infection we've had in the past, particularly in Asia, and from MERS, Middle East virus that have been studied over the last 10, 15 years. So it was easy. We're not starting from scratch looking for the vaccine. We've been looking for it. And above all, money. Governments all over the government, the government with money, have invested a lot of money to support the companies that manufacture the vaccine. It was easy to get global participation. So instead of using one country, maybe only have 1,000 people, you could get 100,000 people within a short time because all the countries were participating. And manufacturing, because normally when you make a vaccine, you take some time to try it maybe on a small population before you manufacture it on a commercial scale. But this time, everything was different. As we are doing the trial on whether effective, at the same time, large-scale manufacture was going on for mass use. Unfortunately, they went on simultaneously and successfully. So we were able to get this vaccine quickly because of the scientists' focus on a single task. The whole world of scientists, doctors, were looking for only one thing, that is COVID vaccine, and they use all their resources. And then we've been helped a lot again by technology, artificial intelligence, and most of you will have been informed that sooner or later, artificial intelligence is going to replace a lot of doctors who can think fast. So artificial intelligence thinks fast and was able to analyze millions of information data in a short time, which will take the human being maybe 10 years to analyze. They do it in less than a minute. And this is the use of artificial intelligence and looking for all the components you need for making the vaccine. And it was also easy to get a large pool of volunteers who would take part in the trial of this vaccine. And so it was easy to make the vaccine. It was easy to use a lot of trial bases. So the vaccine is fairly safe, although so far there are very few side effects. They're rare, but let's face it, every single vaccine you've had over the years has had some serious side effects. And you say that anything that you go into the human body will have effect, even food. Some people react badly to some food. I don't see what noise people are making if they have side reaction to COVID vaccine, because that's natural. You need to have it. And it's possible some people have severe ones, others will not have anything at all. This side effects, some of them may affect their daily activities, but they should go away in a few days. The most common one, which most people feel, is headache, bit of tiredness, maybe pain at injection site, some muscle, joint pain, occasional chill, and nausea. Now, it's not surprising that you feel chills and fever, because when the COVID vaccine is injected into the body, the body treats it as if it was a virus. So it's like it's fighting an infection and producing immune response. And that is what causes the chills and occasionally fever and aches. So it's not surprising. In fact, That is a good sign. If you react and have some fever chills after vaccine, it means your immune system is very good and there's no need to panic at all, because it's a good sign. Okay, so you should not get a vaccine if you have a history of severe allergy called anaphylaxis. The vaccines do not contain eggs anyway, as we've said before. And if you have a history of severe allergy, it's important to consult your doctor so that you can be advised whether or not to have the vaccine. Okay? Women of childbearing age, or potential, who are trying to become pregnant, they can try in the future, may receive the vaccine when it becomes available to them. Based on what we know right now, we believe that COVID-19 vaccines are safe for someone who is trying to become pregnant in the short or long time. There's no evidence that the fertility problem are a side effect of the vaccine. It does not make women vaccine. But all that said, after all, getting vaccine is a personal choice for women who are pregnant or breastfeeding. And discussion with your health provider might help you make an informed decision. So far, COVID vaccines can be offered pregnant and breastfeeding individuals whenever they're eligible. Right now, we don't have data whether COVID-19 vaccines are safe in people who are pregnant or breastfeeding. We do not know that getting sick with COVID-19 during pregnancy also can increase the risk of severe illness, and we might increase the risk of outcome or like preterm birth. These are some of the information that we still need to follow up. At the moment, regarding vaccine in children, the Pfizer one is only authorized for children over 16 years. Moderna vaccine for children over 18 years at the moment is not recommended. AstraZeneca is not recommended at all in children. Younger and adolescents should not get a vaccine at all right now. Okay. Now, COVID-19 does not change, it does not interact with their DNA. Vaccine teach immune system how to fight against a specific. In order to do this job, the vaccine doesn't need to go inside the nucleus of the cell, which is where our DNA is kept. This means that the vaccine never interacts with our DNA in any way and has no way to change our DNA. Okay. How long does it take for you to be protected, and how long will it last? Well, at the moment, we know it takes a few weeks for the body to build immunity after infection. This means that it is possible that a person will be infected with a virus that causes COVID-19 if he just had vaccination recently, and he can become sick or very sick. This is because the vaccine has not had enough time to provide protection. We do not know yet how long the COVID-19 vaccine will provide protection, but we continue to conduct more studies to find out whether the vaccine can keep people from spreading the disease. What we know that the vaccine does not protect you from getting the infection. After the vaccine, you can still be infected. What we don't know is whether you can still be infected or spread the disease. We continue to learn more about the protection of vaccine to provide under life conditions. Until then, it is important for everyone to continue using the old tools available for us to help stop this pandemic, like covering your mouth and nose with a mask, washing your hands, and staying at least 6 feet away from others. Although some of the vaccine producers feel that once you've had the vaccine, and if you are infected, you do not need to go into quarantine anymore. Or if you have been in contact with somebody with COVID, you may not need to go into quarantine as you used to do. This is still subject to further evaluation, but it just gives you a bit of a comfort that you're relatively safe. There are a few questions that often ask that someone who is COVID-19 positive, can you receive the vaccine? The answer is yes. In fact, it's been shown that if you've already had COVID before, if you recovered, if you're given the injection, it's like giving you a super booster dose. So So it reacts much better. You get a better protection, and you may not need 2 doses. So if you've had one infection and get a one dose, you're much better. So you can feel much better if you've been infected and recovered from it. Well, we also know that there are several variants that's going on in the community, and now a lot of people who have already had COVID before are now having more infection. What most scientists feel that this is not reinfection, but this is a new infection. So you cannot say that you get infected again if it is a new variant. This is another complete infection. If you have suffering from COVID, it's not advisable to vaccinate you in the acute stage, because you may have very severe reaction, because your body is already fighting a lot with the virus, and if you add more stimulation, you may get what is known as cytochrome storm, which may be very dangerous. But it is safe to get vaccine even if you've had COVID-19. And it is important that you get vaccinated, even if you have positive antibodies. That will be much better for you. The vaccine cannot give you COVID-19, and I've already explained about it. You may have some side effects like chills and fever. A lot of physicians are scared, even patients, about and overwhelmed about the COVID pandemic. So there's a lot of information about COVID going on digital platforms. In fact, it's said that every day there are no less than 10,000 papers from the medical point of view, which are being put on digital platform every day about the information about COVID. So what you knew last week about COVID is no longer effective this week. And even writing a book or protocol for COVID is very difficult. Now, there's one thing which is very common, that is vaccine hesitancy. And I just go roughly because I know already past my time, and I'm sure Vicky is getting unhappy and jittery. Well, human mind has a tendency to abandon hard rational ways of science and surrender to fantasy in desperation. To be or not to be vaccinated is a personal choice. The choice often does not depend on science, but weighing the risk from dying of COVID. If you're sure you're not dying of COVID, you don't need to be vaccinated. And over the years, vaccination has helped a lot of diseases, not just vaccine, but vaccine hesitancy is a behavior influenced by a number of factors, including confidence, convenience, people accept it or they don't accept it. Some of the major causes I've listed there: disinformation, inability to know how serious the disease is, poor information, and maybe the disease may not. It's a balance between whether you're concerned about the disease or you're concerned about the risk or the safety of the vaccine. Then you can take it. And our leaders, churches, politics, culture, gender, socioeconomic groups, communication, media, environment, all influence as on on the vaccine hesitancy of the various beliefs, attitudes, and health prevention, knowledge awareness. All those will affect you whether or not you want to have vaccine or not. If you can't explain it really, so simply you don't understand it. Sorry, Vicky, I may have taken more than 15 minutes, but I sincerely apologize. Thank you.
No, thank you very much, Dr. Alouch. I think you did very well for me because I guess I have not had the chance to have a vaccine explained the way that you did. I always thought it was a part of the virus that is introduced to my body. So my non-medical side of me is, I now understand how vaccines are then created. And I think for me, the biggest insight to this conversation is just how much we have evolved. When you mentioned that we were able to develop the vaccine much faster because of also how much we can process information. So in the same breath, we can develop the vaccine faster because of the information we can process. And on the other side, the same kind of digital explosion is giving us a lot of information for us to process and leading to a lot of other beliefs. But I want to invite Dr. Githinji. You guys sent me a lot of questions and I forwarded them all to him. And I think, Dr. Githinji, the floor is yours. I'm sure you have very many things to say to the members of Current Country Club.
Well, the first thing I would like to say is that I like your club, and I'll soon be coming to try and join the club. I'm a member of a different club, but I live near now, so I hope to be seeing all of you soon.
You're very
yes, and the next thing I'd like to say is thank you very much, Dr. Alouch, for a very elaborate conversation. So actually, in fact, many of the questions have been answered. Vicky, but I will try and pick some of the ones that were not. But Dr. Alouch has done a fantastic job as always. Let me pick up on a few, but maybe before I do, before Dr. Alouch disappears, I have a question for him, which was listed for me, but because he's a pulmonologist, I don't want to attempt to answer that question when my teacher is here. So, Dr. Alouch, if you could answer this question. Now I'm the moderator for this session. There's a question here that was asked around how do you distinguish between an asthmatic attack and COVID-19 effects, loss of breath? Of course, you've done pulmonology for long, so you could just comment on that. How do you distinguish between the loss of breath in an asthmatic attack and the loss of breath in COVID?
At that moment, we know that the COVID-19 infection may impact negatively on asthma. So now the protocol now, if somebody comes with asthma attack, the protocol that they must undergo a COVID test. In fact, at the moment, for most hospitals, at least in Nairobi, you cannot admit a patient with asthma attack into a general ward until you prove beyond reasonable doubt that he does not have COVID infection. So the question of distinguishes clinically does not arise. You have to do it either by CT scan, and the CT scan has been shown to be even more effective in diagnosing pulmonary COVID than a PCR. The PCR is another more confusing because it gives a lot of sometimes false positive and quite often false negative. So as I said before, now we're using artificial intelligence, and in most countries, if you take an HSCT test and use that, not in the human, but just artificial intelligence to diagnose, it'll tell you 99% chances that it tell you if it's COVID, it will be accurately diagnosed as COVID. So you don't need to bother to validate the attack, because even if somebody is not attacked and has got severe COVID, he'll have some wheezing. This is due to pulmonary fibrosis on the ARDS, will give you some wheezing noises and same dyspnea. So I don't think it's a big issue.
Good. Thank you very much, Doc. And before you go, I have one more question for you, which is on clots. Obviously, cerebrovenous sinus thrombosis. And the question here was, what do we need to look out for on this clot issue? Would you like to comment on? I know I can comment from a point of view of the recommendations by WHO, but would you like to give this a clinical assessment or a clinical opinion on the clots which have been now described by the European Medical Agency as extremely rare events that may arise from the AstraZeneca vaccine? Would you have a comment on that? And then I will leave you alone, I promise.
I don't think it is an extremely rare event. In fact, quite a lot of cases. And if you look at the pathogenesis of COVID, it's easy to understand. And I don't think this is the right forum to go into the pathogenesis of hypercoagulation in COVID. But we do understand it now, what happened. So at the moment, for the non-medics, I don't think you need to worry. You'll be told if you've got some comorbid condition, if it is dangerous for you to have, like if you have had a pulmonary embolism before or some blood clot before, is it safe for you to have a COVID vaccine? Some people say no, others say maybe not. But that's a bit complex at the moment to discuss in this forum. That we leave for another forum. Sorry, not to answer exactly what do you want me to say?
Thank you, Dr. Alouch. All right, so let me now come to some of the questions that were asked by you. So the first question that I would like to address here is somebody said, clarify the rumors on negative effects on fertility, because there have been rumors that the COVID vaccine actually does cause infertility. And somebody talks about infertility among children of mothers who received some drugs to stop morning sickness in 1940. Let me first correct that. That what happened in the 1940s, and this medicine was stopped in 1961, it wasn't infertility that arose. We had a medicine called thalidomide, which mothers used for stopping morning sickness. And then if it was used within the second or the middle of the pregnancy, towards the end, over time people noticed that the children were having congenital challenges. Some of them would be born without maybe arms and stuff like that. So it wasn't infertility. It was thalidomide and it was stopped. Now, the confusion on COVID-19 vaccine causing infertility, it actually came out of anti-vaxxers disinformation. There was a letter written to the European Medical Agency by two known anti-vaxxers who wrote a letter saying that the placenta has a protein which is similar to the spike proteins of the coronavirus, and therefore the vaccine might interfere with those spikes. So there is no scientific evidence, no scientific backing for that claim. It was dismissed, and this myth, because now the anti-vaxxers have an agenda. I must remind you, as Dr. Alouch has said, that when you see this misinformation, it's not by chance. It's actually deliberate disinformation and misinformation. So you must always put that out, that it's deliberate from people who want to, who generally don't believe in vaccines. So when you see something, look at the source. I saw something today referring to a professor in Ireland who was claiming that people will die in 3 or 4 years if they receive the vaccine. And this is a professor, therefore it gives credibility. But when you look back and you search, this is a professor who was dropped out of the university because of false claims. Students wrote a petition, so it's a known anti-vaxxer. And that's one way of cross-checking information. Just searching, because now we have the age of information. Just search the origin of the information. And the origin of this infertility claim was anti-vaxxers in a letter they wrote to the European Medical Agency. So no fear at all that the COVID vaccine would cause infertility. Now, Vicky, I had a set of questions here which actually made me chuckle. One of them was, actually 3 of them were together, and they're all about trust and corruption. And the members here are asking, can we trust? Yeah, I was wondering, can we trust Kenyans not to dilute the vaccine or adulterate it? And we are talking about ourselves here, by the way, ladies and gentlemen. Yeah, is it possible to use an inactivated vaccine because maybe it was stored poorly? And the final question, which is related to this cluster, is what measures are being put in place to protect Kenyans against unscrupulous medical and other personnel? So these 3 questions are the center of our system, of our trust system. Yeah. Kenyans do not trust government. Kenyans do not trust each other. Mm-hmm. This is an issue that requires us to strengthen our surveillance system. Recently, when there was, when there were all the conversations around Sputnik vaccine, mm-hmm. there was a report from DCI that somebody was found with fake Sputnik vaccines. Yeah. This speaks to the center of our ethical and moral standards and our surveillance system. This is the reason that we have fake commodities across the country, not only vaccines. This is the reason we have fake fish from wherever. This is the reason we have items that are similar to others, but they're not exactly the same. So this question is deeper. It's about our moral, ethical fiber, and I'm not sure it has anything to do with the vaccine. But to reassure you, is to say that the Pharmacy and Poisons Board and the vaccine, the extended vaccine immunization program, which is under the Ministry of Health, have been dealing with vaccines for years, tens and tens of years. We vaccinate, we give probably 20 million doses a year to children. on measles, on polio, on BCG for TB. We give young girls HPV vaccine to stop them from getting cervical cancer. We give vaccines for pneumonia, for Haemophilus influenza, for pneumococcal pneumonia. And yet, we have not had a crisis of adulteration. Why? Because there's a system of managing vaccine movement, vaccine cold chain, vaccine administration, and recording batches. Every vaccine you receive has a batch. That batch, if anything happens, you can track it all the way back to the person who administered it, at which facility. This system is what gives us the confidence that unless you go to a backstreet provider yourself, and who is unlabeled, who has no facility number, then whatever happens there cannot be within the purview of the Ministry of Health. But if you're within the system, a public hospital, private clinic, and you receive something that is harmful to you, it can be traced back to the provider. So that's a system on which we rely and depend, because we know that trust can be broken by people who are being unscrupulous and trying to make a quick buck.
So in that same breath, does that mean that you can ask for your own number if you want to verify that the vaccine is actually wherever the vaccine came from? Can you ask for a batch number or something?
Actually, for those of us who have actually received the vaccine, many of us have received, and I know there is a challenge with the system at some points, but many of us have received a text. That text should actually tell you your batch number. That text comes and says you are vaccinated on this day through this batch number. And you can actually ask for your batch number. That's your right. You can say, please, I want to record my batch number for future reference. Okay. But all vaccines, even each vial, has a batch source.
Okay.
So they're not just regular drugs that you just find in a pharmacy. Even when you look at as simple as the yellow fever vaccine, when you get it, that batch, the source and the vial you are given is recorded for posterity. That's why sometimes you can go to the port and they say your vaccine is fake, because they don't believe that batch number exists. So they can track back. All right. So I hope that kind of tackles that question. The next question. Yeah, thank you. The next question is on Sputnik. And somebody wants to know what is going on with Sputnik. Is it legitimately here and valid? So let me give you a bit of a background, because I sit in the National Vaccines Committee. So when we started developing the what we call the National Deployment Plan for the vaccines, there was a point that was made by the government, which was valid, that for us to actually provide vaccines in an equitable manner, but also scale up vaccination, we must engage the private sector. And the engagement of the private sector was in two levels. One, that when the government receives its own vaccines, which I couldn't touch on very quickly, it is going to deploy them through both public facilities and also private facilities, because even now, when we are deploying childhood vaccines, all the ones I talked about, which are free to the government through the Global Vaccine Alliance, they are provided through both public and private. So they are private hospitals, clinics that are appointed by government to provide these vaccines, and they don't charge for them. They actually provide them. Some of them charge a small fee for convenience, but they don't charge for these vaccines, especially faith-based organizations and also many private providers, because they use the vaccine then as a way of providing extra service to the mothers who deliver there, that kind of thing. Now, the government wanted to ensure that this system continues. Make sure you give both the public and private the chance to give the vaccine as fast as possible. The second window for private sector was, is it possible that private sector can import vaccines for the people who are able to pay if those vaccines are available? Remember, there is a global shortage of vaccines. The government said, if there are vaccines, we can allow private sector to import within a certain regulatory and supervisory framework. So that's the background. At that point then, the Pharmacy and Poisons Board was told, please provide an advisory to the Ministry of Health, to the government, on what conditions are needed for any private provider to actually go to Russia, import, go to China, import, or even go to India and import AstraZeneca or any other. And the advisory was provided, and it said the following. One, that the vaccine they import must first be approved by a stringent regulatory authority. Stringent regulatory authorities are few, they are known. FDA is one, the European Medical Agency is one, there's the UK Medical Agency, there are few of them that are known. And as long as the vaccine is approved by that, then you bring it, and then the Pharmaceutical Process Board will review the data and will confirm indeed it can be approved for use in Kenya. So those were the conditions, that you submit the data and make sure there is the support of a stringent regulatory authority. When you bring, it is approved. Now, once you do that, the next thing is to get an import license, because authorization to import, to use and import licensing are different. To get an import license, you are required to provide an indemnity, because these vaccines, as was said by Dr. Alouch, are under emergency use authorization, meaning the government has weighed the benefit of the vaccine over the risks and decided to use it under emergency. And it's not the first one. We have drugs for other things that have also got emergency use authorization. It's not unique to COVID vaccines.
Yeah.
So you are required, because it's not covered for marketing, that you actually provide an indemnity that if anyone ever goes to court, because they can't sue the manufacturer, because this is under emergency use, provide an insurance that will cover anyone who would want to sue for harm. That was the other condition. And that indemnity agreement was supposed to be agreed between the Ministry of Health and the Attorney General. Now, Sputnik went through these phases, but there seems to have been pressure from elsewhere, which I don't understand. That pressure allowed it to get regulatory approval at the Pharmaceutical Process Board, specifically without a stringent regulatory authority, as stated before. Secondly, they got an import license without providing the indemnity agreement in agreement with the Attorney General and Ministry of Health. This is where the challenge has been. So the vaccine is in Kenya. We have about 75,000 doses. Remember, it's 2 doses. They can only give 50,000 people. So you can 25,000 people, because some are mismatched. Yeah. So it's in Kenya. It's stored under -18 degrees at the airport, waiting for resolution of this regulatory mishap. That's the best I can say about the Sputnik vaccine.
Okay. So anyone claiming to have gotten a Sputnik vaccine, was probably AstraZeneca?
No, what happened is, initially, because of what I talked, some pressure from elsewhere, which I don't know, they were actually given the license, including the importation license. That's how they imported them. Okay. And therefore, the pressure allowed them also to actually dispense them. So what they were doing is they were asking people to register, and then you register, because it's required to be under -18 degrees centigrade. So you can't just send it to a hospital. Very few hospitals, you have -18. Even the AstraZeneca is stored under 2 to 8 degrees, which is positive temperature. And many fridges in the hospitals that use childhood vaccines will store AstraZeneca. But the Sputnik cannot be stored in any of our normal fridges. So they required specific hospitals to claim and say, we can actually deliver. Once you actually register, they would deliver the vaccine specifically for the people who registered and administer it and take the rest back to the storage. That's what. So the about 200 people also received the Sputnik vaccine. So they will need a second dose when all these regulatory mishap is actually resolved. Okay. Now, the next question is, can you mix the vaccines? This question right now, relying on the advisory from WHO and the US CDC and Africa CDC, you cannot mix 2 vaccines because they're on different platforms. Imagine, if you go back to what Dr. Alouch said, you have some that are protein components, or they are virus components. There are others that are purely synthetic mRNA, messenger RNA. There are others that are viral vector. So it's advisable that it's advised that we don't mix 2 different platforms because they're not the same. In future, if evidence comes up and says that one immunity can build on another, then a new advisory will be given. Science is always evolving. For now, the advice is, if you receive first dose AstraZeneca, second dose should be AstraZeneca. First dose Sputnik, second dose should be Sputnik. But there's a question that people have asked a lot of times, Vicky, which I want to combine here. What happens to you if you receive only the first dose and you don't receive the second? Is there harm in your body? Is there something like now happens to your body because you don't get the second dose? No. The only thing that you get is suboptimal immunity. Because remember, the first dose gives you the first thrust of immunity. Second dose comes to boost that. It's a booster. So if you only receive one, you'll have suboptimal immunity and therefore no guarantee that the vaccine will work the way it's supposed to protect you from severe disease. So it's advisable you take both doses for that reason, not for the reason that if you receive half, it's going to harm you. There'll be no harm for receiving only one. Just that the harm is you've not protected yourself.
Okay, so is half better than none? Is one better than none?
That's a really good question, because WHO has now recently discussed this issue and said, would you rather start by giving a big part of the population that's vulnerable their first dose, rather than give 2 doses to a very small population? And the general agreement now by WHO is that, yes, that actually, because when you receive the first dose, you receive a boost on your immunity. In fact, the first dose builds immunity by day 14 from the day of vaccination. So it is better to, for especially, and I want this to be marked that, especially in the era of scarcity of vaccines. If you had all the doses you need, everyone needs to receive the second dose of AstraZeneca, specifically what we're talking about, between 1 to 3 months. So first dose, day 1, latest for days 2, or best time for days 2, around 12 weeks after the first dose. Now, the advice of WHO is, in the event that you don't have vaccines at all, instead of saying we're only going to give, and you have only 1 million, instead of giving only 500,000 people the 2 doses, you better give 1 million people the first dose, as you wait for the 3 months, within 3 months to get the other doses to give the second dose. So it's a very good question, and that's the advice right now. That 1 dose is better than none, but you need 2 doses for full immunity. Okay? I hope I've answered that, Vicky.
Yes, you've answered that question. Thank you. I think that once you're done, there are also some questions that are coming up.
So filter them, and I'll finish this very quickly, and then I don't know how much time we have, because this can get very...
It's okay, keep going. I will alert you. But in that same light, there's a question
Vicky,
about...
can I make a comment?
Yes, Doctor.
This is regarding giving those who have had a COVID infection vaccine. Because the people ask, if I've had the COVID vaccine, how soon can I be vaccinated? The fact is you can be vaccinated. But there are 3 factors to consider. First of all is the age. And second is how severe the infection was. And then the third one is what severe comorbidities you have. So this has really to be discussed by your personal doctor. You can not just go on your own and make a decision that you need you've had vaccine. But the minimum, most people say it should be, if you have just had a symptomatic COVID infection, the minimum 3 weeks is what is regarded as safe to give you the COVID vaccine. But the others, it could even take months, depending on the severity of the disease and your age and the comorbid condition. But the important thing is to have the vaccine, but please take caution.
Okay, so that means that even when we've had the disease, we can take about 3 to 4 weeks to do the vaccine, and that's enough? That should be enough? Okay.
Now, you need a second dose.
Okay. Thanks, Dr. Gitahi. Over to you again.
Okay, thanks. So I think to add to what Prof has said, that people are wondering, so because of this, do I need a COVID test before I receive the vaccine? No, the global recommendation is you don't need a COVID test before the vaccine, because the likelihood of what Dr. Alouch explained is that if you happen to have asymptomatic infection and you don't know, because that's the position for majority of people, and you receive the vaccine, you might have a little more increased impact of fever, maybe a bit more fatigue, but it's nothing fatal. So it's important to say that if you receive it when you don't know you have the COVID infection itself, there's nothing fatal, there's nothing that you should be worried about, just that you may have a bit more exaggerated side effects. But if you have active disease, then you need to wait for that active disease to end, and then you receive your vaccine after that. Now, somebody has asked around whether there are people who should not get the vaccine. I think that was elaborately covered by Dr. Alouch, so I don't have to go into that. He talked about, pregnancy and the weighing risk and benefit. The only people, actually, allergy, we talked about allergy, and I've had a lot of people turned away by health workers told if you have egg allergy, you can't receive the vaccine. That was an error from the original document. And it was an error that was moved from There are many vaccines, childhood vaccines, that are made using egg protein as a base. So when you have egg allergy and you're given a vaccine that has egg protein, then you may have a more exaggerated allergic reaction. But COVID vaccines don't have egg protein at all. So nobody should be turned away because they have egg or chicken allergy. And I wanted to comment on that. The only allergy that's contraindicated is if you receive your first dose and you then have a severe allergic reaction, then you are cancelled not to receive your second dose. So that's the only time. Otherwise, no food allergies should worry us. Now, I think the question around whether you can transmit the disease after getting a vaccine, that was covered by Dr. Alouch, that you can actually transmit, you can get the disease even after getting vaccinated, and you can transmit. So just remember that. Is it going to be available and safe for school children 15 years and above?
Just a little modification, Dr. Githinji. We do not have the scientific evidence that you can transmit the infection as yet. So we just, at the moment, we're just postulating that it's possible. Because we've not had enough people with who have had COVID vaccination and have been infected and transmitted the disease. But ideally, it is assumed that you should not be able to transmit the disease. That is our hope. And that's one of the way of ending the pandemic. If you are to transmit the infection, then chances of ending the pandemic are almost nil.
Yes, Doc. And there's a lot of debate again, which we can have here on neutralizing antibodies and whether COVID produces enough neutralizing antibodies or not, whether it actually gives sterile immunity or just effective immunity. So that's a debate that can be had out of this forum. So thanks for that addition. But for now, as was said by Dr. Alouch, if you receive the vaccine, you need to continue with the measures. And the aim is that you cannot get severe disease. But also, even if, as Dr. Alouch says, there's an element that you can still transmit, it is suboptimal viral load. Remember, the severity of disease is also dependent on the viral load you receive. If you receive very suboptimal viral load, then it's likely to progress to symptomatic disease. And that then would help us to reduce this infection. It's just like the flu vaccine, where people get the vaccine, they may get infected, but the shedding is so minimal because of these neutralizing antibodies that it actually ends the pandemic. Children, that was explained in terms of at what level each of the vaccines has been approved. So I will leave that there, as was explained by Dr. Alouch. What would happen if one gets the first dose of the vaccine and is unable to get the second? I have explained that, Vicky, I'm sure.
Yeah.
How soon after a patient has had COVID can they get the vaccine? Again, that has been explained, and Dr. Alouch has elaborated. What are the chances of the side effects taking you down, just like the disease? I think that was covered. The side effects are, majority of side effects are mild. Some people have called and said, I couldn't get out of bed for a day or two. I was feeling so lethargic. This is terrible. Think about your children and when you take them for vaccination and how they cry at night and they have a fever and you are advised to give them Calpo and they are crying for 2 days. And now we are adults. We expect side effects for every vaccine. So we should just bear with them knowing that they're happening for a good reason. So
are you advising us to give ourselves Calpol?
Exactly. Take some paracetamol if you have a fever, drink adequate water. But there is no relationship between getting the vaccine and getting an effect of going to ICU for because of infection, as was explained, or having hypoxia or no oxygen. No, the vaccine will not cause COVID disease. That's the most important message to remember. Somebody asked what the source of information. This is a really good question because people are collecting information from the internet, from social media, as was said earlier. Please fact check. And the WHO website or the US CDC website are very good to fact check. And you just ask, if you saw something saying pregnant women cannot, or pregnant, just say, can pregnant women, and then say CDC, WHO. You'll get a very good advisory. That's the source. Now, the other day I talked about oxygen, and I did a video which went viral. And the reason for this, let me explain, is that on that Saturday I did that video, I had 4 people call me. One 2 days before, one had called me and said, you know, my father is at home. He's a bit confused. He's been very fatigued. I say, have you tested for COVID? No, we haven't, but we suspect he may have it. So we'll see whether to take him to hospital. But he is, you know, when he went to hospital, his oxygen level was 60%. And he was at home talking to people. He had no difficulty in breathing. He was fatigued and a bit confused. That was one. What happened after ICU, they were unable to, you know, to improve his oxygen situation. And in about 4 days, he had a cardiac arrest and he died. He died that Saturday morning. The other gentleman called me from Nakuru, a friend of mine. His father had been at home, again, elderly. All these are mainly elderly people. At home, he'd been told he is COVID positive. For him, there was a test, but he was advised by the local public hospital, you will be managed at home because you are not having breathlessness and you don't need oxygen here. So stay at home, we'll be seeing you. And actually, the doctors would see him maybe once every 3 days, but nobody checked his oxygen concentration. Until this night, when he just suddenly developed extreme difficulty in breathing and he collapsed and died. Now, the third one is a wife of one of the two people I've told you, who also called me that morning and said, you know, just like my father-in-law, my mother is having COVID, but they have been seeing her at home. I said, has anyone checked her oxygen? No, she's just a bit lethargic. I said, no, take her to MPSHA. She was at 60% oxygen. Normal is 95 and above, just for you to see.
Yeah.
And her daughter, who was older at about 61 years, was also at 60%. They were both in the house being managed at home without anyone knowing their hypoxia. So they are now in ICU. So the reason I was raising this point is that it's not people must buy the pulse oximeter. It's also that the public health officials who are managing patients at home under the home-based protocol should take seriously the issue of hypoxia, especially in elderly people or people at high risk, and make sure that if you have a positive patient being managed at home, that the oxygen levels and the saturation is known. So that is really the point I was trying to make here, because many people are getting what, and maybe, you know, Dr. Alouch can explain this better because of pulmonologist, but there's a condition that's known as silent hypoxia, where your body, when you have low oxygen, should actually have a reflex that makes you breathless so that you get the oxygen you need. That's the mechanism. It's almost like when you get pain, you pull away your hand. Your body has a way to react to low oxygen. But in certain cases, especially in elderly and people who have maybe diabetes for long, the reflex is blunted by certain mechanism, which we don't have to discuss now. And therefore, you can have your oxygen going low, below levels that are compatible with life, but your organs are adjusting and you have no breathlessness. So just pointing out that that's a possible thing, and that's why I did that video. And many people have called me saying, we found my father had 80%, we found this person had 70. So that's the point of it.
Just confuse you a bit, Dr. Githinji. Recent studies have shown that the so-called pulse oximeter does not work very well in people of color, i.e., and I've seen it in my clinical experience, you can use pulse oximeter and it shows that the oxygen is 90% saturation. But when you do the blood gases, you can find that oxygen is probably less than 50 at several cases. So it's been shown that we need to devise an oximeter that can be used in the black skin. I think it was meant for white skin. So it's because of the color, it's giving. No, this is not a joke. It's serious.
Let me take it serious.
A lot of work has been done. So we need to develop one in Kenya, Vicky, for us. And Vicky, while I'm on this, can you in future get a bigger hall for the participants? So many of them are complaining that they cannot be let in. You only had 100 people.
I know. You guys are crowd pullers. This is a first as well. So a very interesting topic at this time. And I will apologize to everyone. So
no, I noticed it reached 100 and low. Maybe we should have done a Facebook streaming, but no problem.
That's what I was
And I take Dr. Alouch's point. We need to actually develop one. They are very simple gadgets. The point to make here is that they have an error margin, but as long as they can create, it's not diagnostic. You can create an alert for you to seek medical advice, and then you get a proper pulse oximeter in the hospital, you get blood gases. This is purely just to create the alert and to tell you whether it's okay or not to give you the specific oxygen level. Because then once you get the alert and you see it's below a certain point, then you go seek care, and then you might be told it's actually lower than you thought. So it's an important alert, kind of almost indicative. But the point on how it works and blood skin is taken. I have one that shows I have 95, 96%. So there's some small error margins, but it's indicative and importantly indicative. Now, the final question I had here before you give the ones that you have there is, what advice do you give people with school-going children who are not in the age bracket for vaccination? School-going children are not in the age bracket for vaccination. And what we need to do is we need to follow public health measures like we were doing before. I think Dr. Alouch said that having the vaccine doesn't mean now that we should actually drop our guard. Let me show you one slide here about risk and benefit. I'm sure, I don't know that you've seen this. It's actually, I just picked yesterday's data. So if you look at this, this is actually age and sex distribution of COVID-19 cases, confirmed laboratory. These are not the only cases in Kenya. I will say that the cases in Kenya are many unknown, but based on the indicative dashboard from the Ministry of Health, this is the distribution of all our cases. And you can see where the bulk is. The bulk is between 20 to about 49 years. That's where the bulk of the infections are, and largely male. But look at that bulk. The people above 60 years contribute
very little,
so much less than everyone else. But then look at death. The people above 60 contribute significant proportion of all the deaths. And when you add the 50, you can see it's probably 60%, more than 60%, maybe almost 70% of our deaths are 50 and above, yet they contribute very little here. So when you're doing risk assessment and the need for the vaccine, there are two things we need to look at. One, at an individual level, if you have a risk of death because of age, which is why we have prioritized elderly people, and people with diabetes and hypertension should be prioritized, is because at an individual level, it helps you avoid death, critical disease, ICU, and death. But at population level, then you also need to vaccinate other people because, as Dr. Alouch was saying, we hope that this vaccine also creates enough neutralizing antibodies so that it reduces the chance that if you're infected, you can transmit. So this is the risk matrix. This is how we look at this. And therefore, when you look at children, school-going children, you can see their contribution to infections, even with the schools open, because this is now data from yesterday, has remained under 10% of total infections. That's number one. There is a lot of theories here regarding innate immunity and all these kinds of things, but scientists can tell us, but you can see they don't contribute a huge number of the infections, even when they have been going to school. And when it comes to severe disease, you can see below 19, it's actually, other than under 5s, neonates are getting a bit more affected. But this cluster here is not getting very affected. But can they transmit? Yes, they can transmit. So the question is valid, but they are not very high risk, and therefore they haven't been the frontline priority for vaccines. And also the point to make is that vaccines for children or any research in children and pregnant women requires extra ethical clearance as opposed to the normal population, which is also why the researchers left out those two groups initially, because of the ethical clearance needed and the data that's needed and justification for studies within that category. I will stop there because I know there are other questions. You can ask the others and you can either direct them to me or Dr. Alouch, but I've covered the one that you had shared with me before. Thank you.
I have members here talking about the Johnson & Johnson vaccine and if it's coming to Kenya anytime soon, or if it's in the works.
So I can answer that because it's actually a supply chain issue. So, and there's something I left out. So let me explain this, that vaccines for low income and low middle income countries, especially low income countries, which Kenya was until the rebasing of the economy, are received through a global arrangement called the Global Vaccine Alliance. Now, the Global Vaccine Alliance raises funds from donor countries and uses those funds to buy vaccines, negotiate prices, and deliver them in bulk to countries to become part of the national immunization program. So our national immunization program, which looks mainly at meningitis, now it's cervical cancer was added. We have obviously the issues around rotavirus, where many children used to die because of extreme diarrhea and vomiting. All those vaccines in Kenya are provided through the Global Vaccine Alliance. We don't buy them as a country. But over time, you find that the countries have to contribute a little as you grow, as your economy grows. Like Kenya now is supposed to contribute 20% to these vaccines, but generally they come from the Global Vaccine Alliance. Now, this Global Vaccine Alliance is the one that has partnered with WHO to also do the same for COVID vaccines, find money and purchase on behalf of countries. So Kenya is a recipient, is a qualifying country for this arrangement. Now, which means therefore that this arrangement will provide the vaccines that are cleared by WHO, are available in huge volumes, and those for now is AstraZeneca. Pfizer is not available in huge volumes, is limited to the US and very few doses into Europe. And also we cannot maintain the cold chain for -70 degrees unless you just do it in limited hospitals. So it's not for large-scale public health use in a country like Kenya, Malawi, and Madagascar and the others. So for now we have AstraZeneca, but more recently WHO has approved Johnson & Johnson. And what I've heard is Johnson & Johnson has also done a manufacturing deal with an Indian manufacturer to manufacture on contract. So when Johnson & Johnson is available in huge volumes, it will be added to the COVAX facility. So Kenya may receive Johnson & Johnson in the next few months, in addition to AstraZeneca. But remember, there's supply chain complexity, which also determines which vaccine comes and which one is available.
Okay. So I think for now, guys who want Johnson & Johnson have to travel out. And remember, we have travel bans from living here. But we shall wait for them. The next question I'm going to direct to Dr. Alouch. What happens when there have been some cases of people who've gotten COVID and they've gotten well, but they've had months. Sometimes, I was in a talk of someone who had about 7 months where they were still lethargic, they still had shortness of breath, they couldn't function normal. What happens in such cases? And what's the treatment?
Vicky, there is something which previously it was known as long COVID, but Anthony Fauci has called it PASS, that is post-acute COVID sequelae. That means there are some effects that last long when you've been in brackets healed or cured of your COVID, or or they may disappear and then suddenly they come back. And the common is usually tiredness, lethargy, fatigue, headache, and muscle aches. These are very common to see them. And it's becoming more and more common. There are several medical explanations to this. But the important thing is to know that if you've had COVID, you're not out of the woods yet. You may have the same symptom. Usually come minimum 6 weeks when you have been declared cured, in bracket commas. But it's called long COVID. That's an easier term. But medically, we now call it post-acute COVID sequelae.
Okay, so you're not sick. You just have symptoms that keep
You're sick. If you're not aware you're sick, Vicky, by definition, you may not be having a disease, but you're sick.
What do you mean I may not be having a disease, but I am sick?
Infection. I mean, infectious disease, okay. Yes, yeah. But you are sick. Okay. Yeah.
Okay, I think that answers that question. And then the one of the ones that everyone has been asking, how long does this vaccine offer us protection? Do we have to go for another dose soon after? I mean, after a year, 2 years?
I think I covered that in one of the questions, and I said clearly that at the moment we don't know for sure.
We don't know.
Okay.
I must have missed that one.
And
okay. Sorry?
And we may know. You know, a lot of things have happened too fast in this COVID, and information is changing, as I said earlier, every week. Okay.
Yeah. I have
another. The problem is the herd immunity, as we know it in epidemiology, has not been established as yet in COVID-19. If we ever establish that percentage of herd immunity, then you can probably think of the vaccine having long immunity. But you know, apart from smallpox, that was the only vaccine which was 100% effective. All other vaccines that have been made over the years ranges from 60, 70% or 80% to less than 20%. Like the BCG, the one for getting BCG has been shown sometimes to be in 0% protection.
Okay. So one last question, because I think most of the questions I'm getting here, you've all covered them quite eloquently and extensively, and I think the members have been able to listen in. There is someone asking whether too much steaming, because we've been advised that when you're feeling shortness of breath, you can steam and inhale hot vapor. Is that harmful to your health, and is it recommended for long-term use?
Well, there are a lot of queries about it. Is this in relation to COVID or is it generally?
No,
Because
no,
some
it's in
people use
relation
it.
to COVID, yes.
Well, some people actually use steaming for treatment, whatever it does to. No, COVID is primarily a respiratory infection, as you know. It's acute respiratory distress syndrome. And we know that steaming or some sort of steam inhalation. And over the years, more than a million, 1,000 years now, we'll be using inhalation as the best way to treat our chest ailments. You may know your grandmothers, your grandfathers at home used, when you have the child was coughing, they would burn some smoke or some steam and cover him. It worked. And even the best treatment for asthma was developed by Chinese 1,000 years ago. It was a plant that used to be used as steaming. So steam does relieve respiratory distress. There's no doubt about that. It's been shown. And it's understandable because you inhale it, yeah. So it may not do you a lot of harm, it may do you a little good.
Okay, a little good, not much good. I thought you'd say it's quite significantly good. I believe, unless there's anything else someone wants to ask, I believe we've answered. You've tackled most of the questions that there's this last one. When is Kenya projected? Uh, Let me ask this last one by Charles Ndongo. By when is it projected Kenya will have received all vaccines needed to be out of the crisis? Is there really a projection? From what you're
Yeah.
telling me, it's just a lot of evolution of information.
And here you can't project anything.
Yeah,
Yeah.
yeah.
So
I think
not even bother.
that's like the theme of the discussion. We're learning as we're going. We're learning.
Yeah.
Anyway, so
Not
let me give you one last chance, both of you, just to give us some parting remarks as we wind up this conversation. It's been very informative, but over to you. I think I'll start with Dr. Alouch, and then we can wind up
Thank
with you.
you. The important thing to know that COVID is real and is deadly, and we need to work hard to reduce it. We in the community, we have not come up with a one size fits it all to stop it. So we must use all measures available, and we've been using all the public health measures, masks, close your mouth, do not cough, and
Yeah,
social distancing and hygiene. Now we, in the last 3 or 4 months, we've got the benefits of vaccine. It's
yeah,
just an addition, and it does not replace anything else. It does not make you feel that you leave anything and now you got a solution. No, it's not. It's not the magic bullet as yet. So do not overrate the value of the vaccine. But it is useful to have it, and please do have it. It's a personal choice. Nobody will force you, but it's good for you to have it because it will definitely reduce the amount of virus transmission in our society. Please stay safe, keep well.
Thank you, Dr. Alouch. Yeah, I remember the first time I heard about the vaccine, I thought it was that was the end. And then, of course, we started hearing everything else. So over to you, Dr. Githinji, and anything you want to tell us as we wind up this session.
Well, I want to thank you for the opportunity and for the learning also from this engagement. But I just want to leave this here that vaccines are not an end to themselves, and as has been said, they are part of the overall strategy. And this is what some people refer to as a Swiss cheese strategy, where you layer multiple pieces of cheese that have holes, but if you layer many enough, then you stop anything from flowing through. So if you look at this is what we've been doing: physical distancing, hand hygiene, crowding, but the virus is still part. That's why we're still getting the surges. And as we continue, you have shared responsibility, which may involve government, ensuring there is good air ventilation. Children have open classes, therefore infection is not flowing. Then you have messaging and all these things, and finally the vaccine. So it's just one extra layer in this Swiss cheese strategy. Now, for the vaccine, please, the best vaccine is the one you have access to. So don't stay and say, oh, this one is this one is that percentage, this one is that percentage. That is actually a counterproductive strategy. And remember also, in closing, that when you say a vaccine is 100% effective or 70% effective, as the data has been provided, it doesn't mean it's 67% effective in your body. In your body, it is 100% effective. The effectiveness is from a population study. That is saying, in this vaccine was given to this number of people, so many of them were stopped from having severe disease. Now, AstraZeneca is 100% effective in preventing severe disease. And so is Pfizer, and so is Moderna. So these percentages that we are actually spending time arguing on are actually taking time and energy from ourselves. And I would say, when you make that choice, the best vaccine is the one you have access to. Thank you.
Okay, let me thank you both very, very much for your time and for coming in here. We have learned so much, and we are really, really grateful for having you with us here. Personally, I think I have moved from much close occupying. I may not be in the age bracket, but I'm now a true believer, and I'm hoping our members as well here have been converted to the other side. So thank you, and we wish you the very best this evening, and have yourselves a good night. And to the members of Car and Country Club, the recording will be shared with you. I've seen some questions on the chat, whether it will be shared, and I think it will also be uploaded on our Facebook page. So you can also share with the people who are unfortunate enough to just join in at the last minute and were not able to get in. Unless there's anything else, thank you very much, Dr. Githinji. Thank you very much, Dr. Alouch, and I hope to see you soon, and have yourselves a good night.
Thank you, and good night.